So good morning. As Liz has just said, I am coming at this from something very different than what you've heard this morning. I am a measurement specialist, so I don't pretend to know everything about simulation. I don't pretend to know everything about measurement either. But I certainly, have the skill set to know whether, I feel like something is valuable and enough has enough evidence to say that we can use it in a high-stakes assessment. So some of the things that we're going to be talking about today are sort of the journey that my board has taken to figure out, where does simulation fit in our programs? And so I'm going to give you a little bit of background on the board itself and sort of where simulation feels like it fits into our organization, and then sort of talk about some of the measurement issues that we've grappled with and are still grappling with. And it doesn't mean that you have to have everything perfect to move ahead, but if you're making high-stakes decisions, and we'll talk a little bit about what does that mean? What do we mean by high-stakes decision? And I think the question was a good one. Everything's sort of high-stakes when you fail something. You have to repeat it. So what do we mean by that? So I think, we'll give you an overview of sort of where we are in the landscape of simulation. So some of the learning objectives, because this is CME credit, I felt obligated to put these down, but really we're going to discuss measurement issues to challenge the use of simulation and competency assessment, describe the applicability of simulation to the evaluation of post-licensure physicians. So I'm going to concentrate a little bit on the maintenance of certification and tell you what that's all about. And then the difference between the needs of standards appropriate for high stakes versus what you're calling sort of the directed remedial education, or what I'll call a little bit more formative assessment, although I think there's sort of something in between the two. Let me just sort of tell you where we fit in the landscape, and this might be repetitive for some of you, but I always feel like I need to sort of make this more explicit because I have physicians calling me up and saying, why did you not teach me that better? Why did the ACC? I thought you were the ACC. You were the American College of Cardiology. I thought you were, trying to be the learning organization. And so just to sort of understand where certifying boards fit into the picture in medicine. And so we have many medical specialties out there, and the prior presenter talked about the ones in surgery. And those are really there for teaching, helping you advance, helping you improve from a physician perspective. They're the ones typically giving out the CME and developing the clinical guidelines and publish the specific medical journals. Then we move into the licensing boards, and there are a number of you who work with the FSMB, the Federation of State Medical Licensing Boards, and USMLE and the National Board of Medical Examiners develop examinations for those in licensure. And basically, when somebody gets a medical license, it's a general medical license to practice in the United States. There's nothing about what area are they specializing in. They need to go on to further training to get that specialization. So finally, certifying boards are the ones that give out sort of a recognition, at least to the public, about who's certified to practice in certain specialty areas. Now, the interesting thing about the United States is certification is not required to practice in the United States. Licensing is. And so certifying bodies are still sort of thought of as voluntary, but then hospitals sort of require it. So physicians are going back and forth in sort of going around and around, and it's sort of almost like a catch-22. Well, you tell me it's voluntary, but my hospital tells me I need it. And more we're seeing as we survey hospitals and employers that they are requiring certification, and especially maintenance of certification. So although it's not required to practice, you could put a shingle out once you have your license and maintain it. You do need to think about certification as something that's really important in the United States for identifying specialty areas. So just a little bit about where does American Board of Internal Medicine, which I'm a staff member of, fit in the picture of the bigger landscape of the American Board of Medical Specialties. So the American Board of Medical Specialties was founded in 1917 out of concern for quality of care way back then. And it's the largest self-regulatory group of physicians in the United States. And I underscore that. It's a physician group. It's of the profession but for the public. So it's physicians regulating themselves. And people think that might be a conflict of interest. It's worked fairly well. And we have to keep evaluating, is there a conflict of interest as we go forward in the regulatory body. But there are 24 member boards of the ABMS, and American Board of Internal Medicine is one of them. And we happen to be the largest in terms of the numbers of physicians that belong to us. There are about 250,000 of practicing certified physicians in this country, and about 230,000 of them in internal medicine. And these numbers are, keep fluctuating depending on who's maintaining their certification. Certification happens immediately after training. That's initial certification. But maintenance of certification now, and I'll talk specifically about internal medicine, is for practitioners every 10 years. So in 1990, we instituted a time-limited certification where when you got your certificate, you had to renew it every 10 years. There is still, a controversy about grandfathers before 1990, and they don't have to renew it, and what's all of that about them. Hopefully, I don't want to get into that. I'll talk to you on the side about that. But it is, it is a big problem as we notice the older physicians aren't required to be doing exactly what everybody else is. So what, and the prior speaker talked about these 6 competencies that are really important from the ABMS standpoint, things that we are trying to test in our maintenance of certification program. Some of them are really, really difficult to assess, like professionalism, like systems-based practice. Others are coming along. So we've made great strides in patient survey, interprofessional communication skills. We've actually looked at patient care from both perspective of cognitive knowledge, what do physicians know, but also from, do they know how to diagnose something very well? And also about, what do they actually do in their practice? And I'll talk about that in a few minutes. We, in the boards and the ABMS, just basically have looked at the IOM reports and the talk about patient safety and how important that is. And, I think all of you are very aware of these. But it certainly stirred up something in everybody saying, we've got to do better than what we're doing now. And how do we do it above and beyond our cognitive testing, which we think is important. It tells you whether somebody can make a right diagnosis given a certain amount of information, but that's not it, all of the picture. So what we looked at is, I don't know how many of you are familiar with this Miller's Framework for Clinical Assessment, which was actually put out in 1990. And it's just a nice, really pyramid that helps us understand assessment. The pyramid goes from a very wide breadth up to a very narrow focus. So, at the bottom, you could test whether somebody knows something, and you could do it broadly and do it quickly. There's a lot that you could cover with just knowledge types of assessments. As you keep moving up the pyramid, it's harder and harder to get at the breadth of the field, but you get at specific competencies that are really important. We feel like in our internal medicine program, we're at stage 2 for our internal medicine cognitive exam because we give basically mini case simulations. Every single question in our test is not just about, do I know the recall fact, but it's a case. Here's a patient, presents to your office, here's their labs, what do you do? Now, true, we have 5 options for you to pick from, so it's artificial in that way, but it does sort of go through your diagnostic clinical reasoning skills. We also have something in our maintenance of certification at stage 4, where we actually ask physicians to present data from their practice, say on a set of diabetic patients. And we look at that data and feed them back information about how they're doing in their care relative to how others are doing in their care. And that's really important data for us because it's what are they doing in their practice. Now, of course, they could have diagnosed that person to be diabetic and they're not really diabetic. That could be a problem. But let's assume they are. Are they doing the right things for that diabetic patient? Are they, making sure that they get an eye exam, a foot exam? Do they measure their blood pressure on a regular annual basis? And is that blood pressure under control? And so we feel like we have sort of those areas kind of covered. It's a really hard thing to assess performance in practice. But what we feel like we were missing in our program, and still probably don't have it quite right, is can they show us how to do something in a much more standardized way, especially for procedural areas? And that's where we feel the simulation comes into play. So for fields like interventional cardiology, where a cath lab is a really critical part of somebody's job, or gastroenterology, where colonoscopies are being done, pretty much the majority of somebody's practice is that. How do we get at those skill sets, and who does that work for us, with us, or do we do it ourselves? So I'm going to talk about, again, from a testing organization's perspective, why would you use simulation? And I told you a little bit about, we want to enhance the programs beyond the attestation of the procedural skills or numbers of procedures. So we have requirements in our program. You can't be certified unless you have some kind of attestation that your procedures are good and you haven't had too many complications in those procedures. And we have a number of volume requirement, which we're becoming very, very uncomfortable with. We also don't know that they span the breadth of procedures. Did they get complicated procedures, or are they just doing very simple procedures? So we really don't get at that very well. So we want to expand that. We feel like our current summative assessments are insufficient at evaluating those skills, and I mentioned that before. The higher fidelity practice may yield higher validity of scores. So we want to test that assumption. Will something that we're doing in practice that is really closer to what you're doing really tell you more about a physician than what we currently know about that physician? And we hope that ultimately it'll all increase patient safety. So what's the good news about the measurement for the advances in simulation? So it has become a little bit easier to administer simulations. It's not great. They're popping up at more conferences. We're taking advantage of simulation companies being able to come to you versus you having to come to them. So it's gotten a little bit easier over the years. The skills to be evaluated are getting much more defined, and people are more thinking about testing points and outcome measures than ever before. The outcome measures are more abundant and obtainable and are being captured by the simulators themselves. One of the challenges in our program is we have a lot of physicians, and we're trying to put them through a maintenance of certification program all at once. And, we don't have just, 50 physicians that we have to deal with. We have tens of thousands, over, probably about 30,000 a year that we would have to be looking at. And that's really hard for us to do from a feasibility perspective. So the more the simulators can capture the outcomes, the better off we're going to be. The scoring approaches are becoming more and more sophisticated, and I'll talk a little bit about that as we go on. The methods of equating, and I won't get too technical here, but we need to understand that when I give you a simulation this year versus last year versus the year before, I make sure that changes in the simulation are working well, but I don't want to give you a very different test than your fellow colleague got the year before. We've got to be able to make sure that the fairness measure is applying across years. We'll talk a little bit about reliability and reproducibility of our decisions. In other words, I want to give you a simulation, but if I gave you some other sample cases, would you come out the same way? Would you come out different? What's the breadth that I'm covering? I have to understand how reliable it is when I make judgments about you. Is it just for these cases, or is it for all cases that you're going to ever do in life? So, we really have to worry about that when we make judgments about physicians. And the validation studies, they're few and far between, but they are slowly being done. I'm afraid that people don't always call them validation studies, and what one sees as a validation isn't always as obvious unless you use the word validity in the paper. So, I think they're out there, but they're not as abundant as we'd like. The not so good news about simulation is there are still technology limitations. They're getting better, but that shouldn't obstruct us from moving ahead. But we've got to recognize them. We've got to know that they shouldn't stop us from moving forward. We did a study, and I'll talk a little bit about it. But I was surprised that there were a few physicians that stormed out of the study because, this would never happen to me in practice. This doesn't feel right. And so, you have to be really careful with the simulation. If it doesn't feel like what you're going to be using in practice, there could be sort of a negative behavioral aspect to this. And so you have to manage that as well. We don't want to construct what we call irrelevant variance around the assessment that we do. It's just because they're not familiar with the simulator that they're not doing well. You don't want that to be part of the assessment. So you have to really make them comfortable with the differences between the simulation and what's in real life if you're going to measure them on the simulation. We want to minimize false positives and negatives. So when I say somebody's certified and has passed this thing, I want to make sure I have the right number of cases. You have to, if you're doing ratings, you need to have the raters trained. You need to have the right number of raters. You can't make it about one rater rating a physician. So you really need to worry about, if this is a high-stakes decision, am I making those decisions well? And standardization is difficult. In assessment, we like standardization. We like to have everything the same for everybody under every situation. Well, in simulation, it's not going to be that way. And how do we deal with that diversity? And how do we acknowledge that, it might not be perfect and we can make decisions without that standardization? We need to be able to make valid differences based on the scores. And automating scoring rubrics are very complicated. It's not that, you think it's easy. It's easy with time. The shorter the better, but it's not that easy to figure out. A lot of times there are more than one ways to skin the cat. And so how do you figure out, whether people are getting credit or not for what they do? It's easier when you have an error being made and you could take off points for that, but it's really hard to say, was this the most efficient path? Even with the experts, and we'll talk about that a little bit. Adequate sampling of the domain is constrained by the time. So in a real high-stakes assessment, you have a certain amount of time. You can't be putting people through testing for days and days and days. So, do you want the case to be really high fidelity and just what you'd see in practice? Do you want to make more smaller clippets of that case and just test up to a certain point and have more cases along the way? So those are the questions that we have, and I don't think we've resolved what's the best way to do it. The other thing about high-stakes testing is, are the cases very memorable, so that when you walk out of a case, I'm going to need lots and lots of cases in my program so that you can't tell your fellow person next to you, I just came out of this case and this is what you should do. We want it to be a true assessment. Now, it's not bad if you learn from that. So there's this formative piece of that. Well, is it bad that they tell each other? Well, again, depends what you're using it for. And of course, as we talked a little bit before, cost and logistics are really a problem still. I won't get into this really deeply, but there are lots of different ways to go about scoring. There are checklists, and depending what your outcome measures are, there are different uses for these. Checklists are often used with the standardized patient model of simulation. There's also ratings, which are much more holistic views of how a person is doing. And then there's the more technical regression-based or rule-based scoring, which actually the National Board of Medical Examiner uses in their Case 3 simulations. So they actually have gone from, I think, a regression-based, and tell me whether I'm right or not, a regression-based model to a rule-based model over the last few years. And so, that's hard work. It's not that trivial. It's really hard work, but it actually makes it so that it's a much less subjective task. And I think that's where we're all headed. Reliability and reproducibility, multiple cases and scenarios are needed. Shorter cases, as I mentioned, and duration might be the way to go. Is there internal consistency with one case? Like, does a person do well in one thing and not in another? And should we be worrying about the final outcome or the steps along the way? So I think we have to think through those issues. Again, I talked about generalizability studies and sources of error. There's lots of sources of error when you're doing cases. How many cases, how many raters, the interaction of the cases and the raters if you are using raters, and task specificity. Did I pick tasks that are so specific that it won't generalize to other things? The reproducibility of the standards as well, and again, I mentioned that before. The validity, and I think, Dr. Satava mentioned this before, content validity and construct validity. I'll give you some examples of that. But, did you cover the breadth of the field? Do you have the right testing points? Did you start out with a blueprint and you know what your outcomes are supposed to be? Construct validity, are the more experienced people really doing better? Do you have any evidence that your cases are working in the direction you thought they should? Is there a relation to real outcomes? Do they do well on the simulator but not in real practice? I mean, you got to worry about those things. Somebody could be I worried at one point, maybe my son who's great at computer games could step up to a simulator and do really well. What does that all mean? And we need many studies to build the body of evidence. It's not one study you do and then you quit. So I think that's sort of an iterative process. Now let me talk a little bit about the differences between the summative and the formative pieces of assessment. So I tried to sort of say to myself, well, what's different about simulation in these different arenas? I'm having a little trouble seeing this screen here. But so in terms of the primary goal, I think, the major differences, and I don't think they're so different. It's about timing and when you give the feedback to people, but there is a little bit of a difference. So the primary goal for formative assessment is really for the physician themselves. Ultimately, it's for the patient, obviously, but it's feedback to the physician to know whether they need to improve or not. In summative assessment, it's really about the public. We want to send a message out to the public that this person isn't ready. There's something wrong with them, or they are ready. And so, again, it would be nice if everybody was at 100% competency, but we at least need to get them to a level of competency that we're comfortable with. So the real difference between summative and formative is I think the public needs to know about the summative part of things. They need to be engaged in knowing that this physician is not quite ready. The measurement concepts, really when you focus on measurement, there's a whole utility model that we use to figure out what are the most important things. From a formative assessment, it really is the educational impact and the feasibility of doing it in a program. But from the summative assessment, you really have to worry about reliability and validity. What are your inferences that you're going to be making to the public about the statements that you're making? Standardization of cases is important in formative, but it's actually essential in the summative world. So, I can't make statements about people and make it fair if I'm wildly different in my simulations. If I give you a really easy one and give somebody else a really hard one, well, we got to have some kind of standardization. And again, I don't mean it has to be exactly the same everywhere, but we have to have some criteria that we work under. The breadth of the skills, how important is to cover a wide variety of skills rather than a specific thing. I think it's important in the formative, but it's actually essential in the summative if what you're making is a statement about this person is ready to go out in the field and do these procedures. So you need to be able to make sure you cover that breadth pretty well. And it doesn't have to be all done through simulation. It can be done in a variety of ways. The stability of the simulator actions need to be there. And as I mentioned before, if you're getting a lot of variability when you use the simulator, it keeps breaking down and there are technical problems, you're going to get frustration on the part of the physicians using the simulator. So we really have to work on trying to figure out how to maintain that and keep it focused on it is a good product and it is a tool, and we have to recognize that. The scoring rubric itself, you really want some very detailed feedback and on-the-spot feedback for formative assessment. Whereas, in the more summative assessment, a validated approach is what you need, and you need to get to a sentiment that, you passed or failed, and you need to give them some feedback, but the feedback on the spot is not the thing that we focus on. Case fidelity is important in both situations. You want to make it seem real, again, depending on what you're looking at. And finally, the automatic metrics being captured is useful in formative assessment, but not essential. You could be standing there and nothing's being captured, but somebody's observing and you're telling them, no, you spent too much time on this, or you did this too erratically. Whereas in summative assessment, it's just really essential from a feasibility perspective. Now, the simulation and technologies that we looked at when we started this were a wide variety. We actually looked at sort of the typical ones that were out there, the standardized patients. We looked at case-based simulations, so making it a little bit more open-ended on a computer. But we also looked at part task trainers, the more computer-enhanced life-size mannequins, as well as virtual reality. At the time when we were looking at it, the virtual reality really wasn't that popular. So we sort of ended up talking about, where does it fit in our program and where should we start looking at it? We thought about all the specialty areas that are under internal medicine. Now, internal medicine has about 18 subspecialty areas under it. So cardiology is under it. Pulmonary critical care is under it. The geriatrics is under it. So there's some more cognitive areas and some more procedural areas. And so these are the general skills that we looked at. We looked at critical care and pulmonary. We looked at internal medicine in general. GI, and interventional cardiology. And we just sort of said, where do we start and how do we think about this? Where would it add most value? And what we ended up was thinking about interventional cardiology as our first place to start, because we felt like our cognitive exam was so far away from those procedural skills that we needed to start looking at, can we adapt something for them? So we actually did a study and was published in Simulation in Healthcare in 2010 with Medical Simulation Corporation and our interventional cardiology test writing committee, who developed cases on a simulator, and we actually put it through a big case study that was funded by our foundation to just see where are we, what do we know, what do we understand about the measurement properties of this thing, and how do we move forward after this. So the research protocol, I'm not going to get into a real, talking about the study itself, but just to get you a sense of what we did, we looked at questions about we gave the physicians that volunteered in the study questions about their training, practice, procedures. What have you done in the past in your life? Tell us about yourself. We surveyed them about their experience with the simulator afterwards. So we gave them a little bit of a survey afterwards and talked to them about it. We had them practice on a case on the simulators and made sure that they were up to a sufficient level with the simulator before they proceeded forward. So, you don't want them going into cold into a simulator. You need them to practice on and understand how to make their decisions with it. And then we developed actually 6 cases that we had delivered. We had a whole blueprint of what do we want to test. Some of our limitations in that blueprint were that the simulator at the time couldn't test some of the things we thought were important, so we didn't test them, obviously. They just weren't up to the fidelity, and the tactile forces weren't there, so we ignored them. So we knew we weren't covering the breadth of the area. But we tried to use real clinical scenarios, some with complications, and mostly things that actually had a cognitive component to it. So like, what's the right drug to give in this situation? Would I refer somebody to the ER after this? Not just, can I put the stent in the right place? And we looked at these six scenarios, and they took about 20 minutes each. We counterbalanced. We didn't give everybody the scenarios in the same order because some were a little more difficult than others. And we collected the metrics automatically with the simulator. We also had, as an external validity thing, a global rating by the clinical specialist that was working the simulator. So we thought, while they're there, we might as well have somebody rate them, not just what's being captured on the metrics, but what they felt like, how comfortable the person was using that simulator. And then we actually used rule-based scoring logic that we took from others that have done this work with the subject matter experts. So there were 120 subjects in 10 clinical sites, and we looked at 3 different levels of expertise. And we're not sure we got the levels of expertise right. What do you call a novice? What do you call a skilled person? And what do you call an expert? But these are kind of the levels that we categorize them in. So a novice was somebody who wasn't totally a novice. It wasn't like my son, who's a computer science major, doing it. It was somebody in the cardiology area, so they knew something about what was going on, but they weren't skilled in the interventional procedures. And then skilled were sort of the levels of fellows and somebody who's out of training just a little bit, and the experts were people out of training for many years. And what were our survey results? Well, the case histories were fairly clearly stated. We really wanted to learn from what we were seeing. And what we found were, the tactile forces were not simulated as well as we would like. The advancement of the catheter wasn't as simulated as well as we'd like. And so, we learned a lot from these surveys. And it's not so much important the numbers, but the simulation company learned a lot. We learned a lot. And, this is published in that paper that I talked about before. We also just wanted to know, did you get a proper orientation? And, was it user-friendly? How were we doing this study? And we felt like we got a good, assessment of what we were doing. True, these people were volunteers. True, they were interested in simulation. So, if you gave this to somebody else who wasn't, would we get the same responses? Probably a little, this is probably a little bit more gung-ho positive than we would expect. So what did we find? And, so from a measurement perspective, we were, not shocked with what we found, but certainly not feeling like we could go way ahead into high-stakes assessment with this. So for those of you who know about reliability, or reliability of 1 is the best you could ever have, and, your rulers, when you use a ruler as a measurement tool, you expect when you measure something with a ruler, you're going to measure it again and get pretty close to that same measurement. Well, with these kinds of tests, you're never going to get perfect. but you want to get pretty close. So with our cognitive assessments that we do in you know, the exams, the written exams, the SATs, you know, all the things that your kids take as they go through school, those reliabilities are way above a 0.9. You know, they're really high. Purposely, because we want to make sure that we make reliable decisions about people. Well, for these 6 cases, we got a reliability of close to 0.7, which wasn't shabby for just 6 cases, but it's still not feeling like I feel like I could go ahead and say this is a great assessment. So, you know, that makes us think, you know, how do we go backwards and say, what do we need? You know, maybe smaller cases with more testing points in them. You know, maybe the cases weren't quite right. And there were some cases we felt like didn't do a great job. So we learned a lot from this, but at least we were honest with what we got. We're not going out and saying we have it all made. Validity, we tried to say, you know, does this correlate with anything else in the world? So we looked at, you know, what did this clinical specialist give them in a rating? And so we got a medium correlation, which we thought was fairly decent for what we were doing at this point in time. It wasn't perfect. Again, correlations of 1 are perfect. But this is pretty typical in the industry for validity measures. The percent of time people were performing these therapeutic procedures, you'd think the more you perform, the better you would do on the simulation. So that was also significant. And the mean number of procedures that they actually had done in the last year was really important to us because that had something to do with the experts versus the skilled folks. So even though these aren't, you know, totally strong correlations, at least they were going the right direction. And here's what we found, and again, this is in the paper. But what we did find was that we had pretty different experiences with the novices and the skilled and experts all along the way, the cases themselves and the total case. But the skilled and experts we weren't differentiating well at. And so we were kind of perplexed by that. You know, what's going on here? You know, are these cases bad? Are the experts not the right experts? And we're still sort of mystified by some of it. But when we set out to do the study, our main objective was, in fact, to distinguish between novices and everybody else. We wanted to make sure that the simulator was doing something, that it wasn't just my son who was able to take the test being able to pass this thing pretty easily. Then we also started getting into the experts and feeling like, well, some of the experts that we had were people that weren't actually doing procedures anymore. They were people teaching. And so were they the best people for us to be considered as the experts? So we still have sort of an issue of like, who are our experts and you know, how do we decide on that? So our conclusions were, you know, we distinguished at a certain level, but did not distinguish between skilled and experts. Our reliability was satisfactory for a more low-stakes testing than a high-stakes, but we had some evidence of validity. So we felt like, you know, we can move forward. And as I mentioned before, our study limitations are a convenience sample, the fidelity of the tactile forces. We also, an interesting thing is we did end up putting in what we call a talking head, and I don't know how many of you are familiar with a mentor or talking head popping up in the middle of your simulation saying, you know, you're going off on the wrong track, come back and do something. And the reason we did that was we felt like, well, if somebody went off totally on the wrong track, they would just be sitting there going on and on and on, and we couldn't get them back and assess anything else that they can do. So we put that in, but it's not real to practice, although, you know, as we work in teams, it might be real to practice. You know, somebody might be standing there and saying, well, why don't you try this? Why don't you do this? I think you did something wrong. So, you know, that's something that, again, we're grappling with. In terms of our implementation now, you know, so what do we do with this? Where do we go? And so what we decided to do is we contracted with the company that we work with to actually deliver these, but deliver them in a low-stakes environment. So we're now having them as part of our self-assessment part of the maintenance and certification program. You don't have to pass or fail them. You just have to get used to doing them and just get looking at what are your procedural skills relative to others that are going through the program. So we're trying to give a little feedback. We know the cases out there are old. You know, they need to be refreshed, and we're talking about now refreshing these in the environment. But we feel like it's a good introduction. The interventional cardiologists like the idea of doing this. They could do it at conferences. They could do it at fixed centers around the country. There are other testing venues that we've tried, like bringing a simulator to a hospital at certain points in time. So we're still working on the feasibility. We're collaborating with other societies to work on this, and that's why I asked the question, you know, how do you get the societies to work together? We provide a feedback report. It's a very simple feedback report at this point in time. We weren't quite sure where we were going, but we told them about the cases and how they did on the cases, what percentage you get correct. This is just a specific case, a specific person. Actually, it's a made-up person. And then we also say, how did you do relative to others who are in this program? So, if I look at my overall performance and I got a 79%, I was in the 90th percentile. I was doing better than 90% of the other people. So, just to get a sense of, where am I in this picture? So our next step is a better understanding of the state of simulation for interventional cardiology, and we're working closely with the American College of Cardiology and then SCI, and John Messenger is, helping us do that to really sort of figure out where do we go next with simulation. Do we, as ABIM, have to develop them? I don't think so. So, how do we partner with others to do that? And some of the barriers that, we've talked about before. We actually surveyed vendors for the state of simulation, and I won't go into that today. We also surveyed program directors. So I'm going to show you a little bit about that and what we did. It's really hot off the presses, so I ask you to be patient with me because I haven't really looked through the results. I added them last night because I thought you'd be interested. And we want to investigate simulation in other disciplines. And one of our biggest challenges in internal medicine is that we have so many disciplines, and there's so much there, and we really need to start partnering with societies to make this happen. So just a little bit about our survey findings. So we thought, well, let's try to check the state of the world, at least in fellowship training programs. And again, it's in the fellowship training programs, specifically in interventional cardiology, a one-year training program. And we wanted to know, of the 132 fellowship programs, who's using simulation and what are they doing with it and what do they think about it. So the sample that we had was the 132 fellowship programs, and we have a really good relationship with our program directors. We only got a 45% response rate, which was really sad for us. Why can't they help us understand what's going out there? But it's not a shabby one when you think about survey research. 83% of the people that answered the survey were program directors, 5% were associate program directors, and then there were others that were, sort of heading up the simulation center. We're not sure they were the right people to answer the survey. So, there's a lot of still we've got to go back and qualitatively analyze this data. So I take it with a grain of salt. But only 24% of them said they use a simulator to teach cardiac catheterization lab procedures. So that was whoa, what's going on there? And we did ask the question, do you let it happen at conferences? Do you let it happen at other hospitals? It didn't have to be at your site. You didn't have to own the simulator. But only 24% of the 45% response rate that we got said that they were using it, as a teaching tool. So that was kind of a little discouraging for us. Why not? So we tried to get at some of that. 58% use simulators to teach other areas. So maybe there's something about the financial models in the other areas that are a little bit easier to deal with and the feasibility to deal with than in interventional. So we wanted to look at that as well. And here's sort of the amount of time that they state their fellows spend on the simulator. And, you can see there's a wide variety, but it's not that many days per year. We were talking about before, they should be on there every day. Well, they're not. And why is that the case? Is the simulator not open? Is it the 80-hour work week? What's going on? Is the culture in the organization? And then we also looked at, what's going on here in terms of the statement about, the procedures and the things that you're using on the simulator and what's good about it, what's not so good about it. And as you can see, from the left to the right, we ordered this in, who agrees with these statements. And, it sounded like the technical support, if you had a simulator, was good. But on the other end, the experience wasn't exactly as similar to the cath lab as we thought it should be, or the advancement of the catheter wasn't simulated well. And this has nothing to do with the study that I did before, but we were getting sort of very similar results still. And this survey was just done in the last few months. What did the respondents like most about the simulator? Sorry, I just did something. And these were some of the comments that we got that I thought were, really interesting and not so different from what we've heard in the prior two sessions. But it allows a more objective assessment of the training, and I think that's a really important part. It's not as subjective as what we had before. And it helps people do things in a situation that isn't real, and they can make mistakes, they could fail. So they were really happy about that. It's simple, convenient, and available when you have it in your program, so you could actually go to it and work on it. Uncommon scenarios and complications can be simulated, and that's something that really is hard. You can't predict who the patients are that are going to show up in your hospital. And so simulating something that might show up in a very rare occurrence is really important. The ability to create those complications without putting a real patient at risk, as I just said. And it allows the fellows to experience things as the primary operator, even though they might not be the primary operator in a lot of situations. So they could see what the other person's going through in a sort of simulated live setting. What did they like least about it? Less realistic than desirable, doesn't replicate the real live cath lab. Additional feedback in the future could be via videos from the actual production. The tactile senses, as I mentioned before, limited in types of cases, so there wasn't as much of a variety as there could be out there on the simulators. Again, the same, these are sort of separate, but the same for some of the less likely. And the financial burden of using the simulation and the need for a more central simulation center. Why are we all working separately? And I think that came out pretty resoundingly. And this is really a busy slide, but all I wanted to tell you is that, people have different views about the use of the simulator. What would I use it for? What do I like about the simulator? Why do I need it for teaching? They didn't think it was so good for fluoroscopy procedures, to assess that part of it, but they liked it for, valve replacements and valvuloplasty, some more sophisticated things. So they felt like they could do the other things probably in some other methodology, in a teaching mode, but they felt like the simulator, we should concentrate on these things on the left more. That's where the simulation companies should focus their energies on. So in summary, basically our measurement issues challenge the use of simulation and competency assessment, but they are being addressed, and we're slowly learning more and more about, how can we do this in a fair and valid way. Simulation may be able to use for summative assessment for post-licensing physicians to supplement live patient cases. So an intriguing idea, especially of our board of interventional cardiology, they basically feel like, well, there are some procedures that everybody does. And, you could get that from a log. You don't need it. But these rare cases, I really want to be able to supplement what they currently can tell me about what they're doing in practice on a simulator. We have the technical and cost barriers to overcome. And finally, the needs for the high-stake competencies assessment are slightly different and may be more difficult to achieve than the needs for remedial education. So in remedial education, some of it is about just, here are your errors, fix them, understand them, get better. Whereas in summative assessment, we're really out there telling the public this person isn't ready. They haven't, just like the pilot who's not ready to fly that plane, we're telling the public that this physician isn't ready. We don't have to advertise it all over, but we're not letting them get certified until they get there. And so how do we do that better? And, where does it go from here? And so, I don't know if you did that or I did that, but thank you. That's basically my presentation.